Thank you, David. Thanks for the invitation. I'm sorry I'm a bit late. Because it's in Leeds, I went to work this morning and then thought I knew where it was and then parked in town and walked here. So I apologise for that. And thanks for the CLLSA, who've been very supportive of our trials over the years, with Gary and other members. And also Jeff, I should mention Jeff Cross, who I dragged in because he's my IT person. Whenever my computer breaks, I give Jeff a phone. And so he's set up this device. Well, when I speak to patient groups, it's always difficult because we always have a mixture of understanding of the disease and the treatment. So what I thought I would do, and also I don't like to do slides in these sort of meetings because they're boring enough when I watch them and fall asleep. So it's easy to get lost in it. So what I've tend to find it useful is to pretend you are a new patient and describe CLL to you the way I describe a patient. I always draw pictures, as some of you in the room know, and many of you probably still have the same picture that I draw. So I'll do that, and then I'll talk after that about the therapies, and particularly the new therapies and how they work, and why it's really changing the outlook for CLL going forward, as I'm sure many of you have read. And then, so that'll be the morning. You can interrupt me at any point, you can ask questions, you can shout, just don't throw anything, unless, well, money's okay, but anything else, just don't throw. And then at the end, I'll probably talk for about half an hour, then we can have a chance for questions afterwards as well. So if you've got questions that can wait, just remember them, we can talk about it later on. We're going for about an hour. And then afterwards, David Buchanan's come, and he's been, I've been working for him, or he's been working for me for at least 15 years as leading our clinical trials team in Leeds, and one or two of you will know him. And I've not seen Tom or Katie, but they're coming. So one of the patients who's been in our trials to talk about the experience of that. So is that okay? Yeah, fine. Okay, so this is going to be very basic for many of you to start with, but I'll get more complicated, I promise you, and I'll try not to get too complicated. Okay, so I always find it's really useful to describe normal blood to people before we start to describe what's wrong with CLL or any disease. I mean, it's like when I go to a garage with my car, I've got no idea how it works, and if someone tells me some jargon, I just don't understand how it works. So it's much easier to try and understand normal blood hemopoiesis, or blood production, and the immune system, and then you can actually put in context the disease and also the treatments, because the treatments that we're getting now are really developed on the basis of understanding the disease, and that's what's really changed in the last 10 years. So the first bit's, I've got multiple colours, so I might even try to get multiple colours. I always do these in black and white. So normal blood. Can you see this? I don't know. Yeah? Okay, very good. So Jeff's got past the first base. So we have in the blood, we have three types of blood cells, and I'll break this at some point, and then Jeff will rescue me. So we have three types of blood cells. We have white cells, which you're all familiar with. I'll just put white cells, which fight infections. We have red cells. I'll put them down here. Never quite enough room on these things, which carry oxygen around. That's the hemoglobin. And we have platelets, and they stop us bleeding. So the blood cells last for between 5 days for a platelet, up to a week, up to, well, months for red cells, and between days and years for white cells. So they have to be continually manufactured. So the factor that's making the blood is the bone marrow. So it's still working. So in the bone marrow, if we look at a normal bone marrow, and some of you have had the unpleasant experience of having a marrow, they're not always unpleasant. David's very good at doing them, so I've used to do a few, but less so now, but still the odd one. If you look at a normal marrow, what we see are all the cells being made. So it's the factory that makes the blood. And so we see a very organised system of immature cells to mature cells until they're ready to come out into the blood. And the most important cell in the bone marrow is the stem cell, which we've all heard of stem cell research over the years, and it's really critical for many of the degenerative diseases that we're going to be treating in the future, because they're caused by the wearing out of stem cells a bit effectively, or exhaustion of stem cells in all tissues. But in the blood, the stem cell can turn itself into a white cell, red cell, or platelet, but also makes itself. So we don't run out of blood when we get to 11 or 12. We keep replenishing the marrow stock, like reseeding the marrow. And the marrow's very busy, so we're making thousands of millions of cells an hour all the time to keep up what's being lost. So it has to be very carefully controlled. So if for example, the white cell count goes too high, the body sends a message back to say slow down a bit. If it goes too low, it gives it a push to make some more. So it's a bit like a thermostat. It's kept in a very tight balance. Okay, so and it usually works very well. Of course, it's much more complicated than that, as you are all aware. There are lots of different white cells we have in our blood, in our body, and we call them different names depending on where they go to. But the two critical ones are neutrophils, and neutrophils are really our first line of defence. So neutrophils fight any infection. They're not specific, but they're really important. While we're sitting here, we're getting bacteria and from our mouths, from our bowels into our blood all the time. So our body has to stop it causing a problem. And so it continually clears it away with neutrophils. That's why having very low neutrophils is likely to lead to infections, because those bacteria can grow in the blood. So they're very important. They're a bit like a hoover. They just hoover up any bugs before they cause a problem. The second important cell, which I'm sure we're all familiar with, is a lymphocyte. And the lymphocyte is our immune system. So what that means, I have to try and change now to another sheet. I've not to use any colours yet, that's a bit disappointing. Okay, so the immune system, which the lymphocyte is part of, is really probably one of the most impressive cells in the body, actually, because if you think about it, what the immune system does is it recognises bugs that, like any bug we see, viruses, bacteria, anything we see in the environment or we get infections from, and then specifically changes to attack it. So it produces a cell that will only, for example, attack measles. And if you imagine designing a system that can do that, when it's never seen bugs that may not have even come into any human before, it has to be able to react to that system. So that's a really complicated cell, because it has to, it has to be very agile. And that cell is we pay a cost for having an immune system. If we don't have an immune system, if we are born without lymphocytes, and that happens, those children don't survive, and they're the bubble babies that we see, on the news. Because some of those children, just for a variety of reasons, don't make lymphocytes. And actually, those children have led to us understanding lymphocytes a lot more. Because if they're missing one thing, we can understand there's a problem in the lymphocyte, for example. So over the years, we've got a lot of information from that. So we know lymphocytes are critical. So we have billions of lymphocytes floating around. They live in our blood, marrow, spleen, lymph nodes, anywhere where bugs might be as well. And they're waiting for us to get an infection. And when we get an infection, I always use measles as my example, which doesn't look like that, but that's my measles virus. We get a sudden sort of invasion of measles, and our neutrophils don't deal with viruses, so the immune system has to cope with it. So what then happens is the lymphocytes busily start trying to recognize it, and they mutate themselves. So they have, if you like a Lego set that they put together in random order to make what's called an antibody, and we're all familiar with antibodies. And so what will happen then is, after a day or two, which is impressive, one lymphocyte will be developed that produces an antibody. These are what most antibodies look like. These little protein tags like a Y, which in this case will link onto measles, because they recognize it. And then when the body sees something coated in antibodies, it kills it. So that's why we get better from measles or mumps or any other infection we have, that the body learns it shouldn't be there and attacks it. And I'm not going to go into details of that, because it's, but we do understand a lot about why that happens, and we're doing a lot of basic research now on understanding why that lymphocyte can go wrong. But if one of the things that happens then is, once you make a lymphocyte that is now specific to measles, that lymphocyte will grow from one cell to billions in a day or two. So it can grow at a really phenomenal rate, because it has to kill the infection. Gets rid of the infection, and then you don't need billions of anti-lymphocytes, measles lymphocytes, so then they kill themselves. And so they have to delete that side of things, and so they kill themselves. But we want some left, because we want to be able to remember that we've seen measles before. And so they kill themselves in a few days, but some of them stay alive and become memory cells. So we have a cell that is designed to mutate itself. That's a dangerous thing to do. Can grow at probably faster than any other cell in the body, which is dangerous. Has to kill itself. If that goes wrong, there's a problem. And then has to live forever. And so that's really a cell that we pay the cost of having. And a lot of our lymphomas, leukemias, are because of that the sort of inherent danger, if you like. So all that action happens in the lymph glands, in the spleen, and mainly the bone marrow. And so we understand a lot about that. So that's normal. Is that clear? Yeah. Okay. Okay. So what happens next? Well, if we look at CLL and if we test the general population, we find CLL cells in many people actually at very low levels. So in 60-year-olds, we've done this a lot of research with Andy Royston in Leeds. In 60-year-olds with a normal blood count, we see 6% of patients have CLL cells, and they're exactly the same as the disease, but they just don't come up on a normal blood count. And if you're 80, it goes up again. So as you get older, the proportion of patients increases. Those individuals are not patients. They will very small proportion will go on to develop CLL. So because we've done the studies, we know that's the case. But they're probably the sort of precursor to clinical CLL, that something else happens that makes those patients sort of go more out of control. So what happens with CLL is when a cell has to grow, and this is stem cell, any cell, it copies itself. So the two daughter cells, I'm sure I'm better at drawing on a bit of paper, but never mind. The two daughter cells are identical to the original cells. That means it copies all of its genes, because the genes are what steer it. And we have about 30,000 genes and about 4 billion letters of code, copies in seconds. So that happens all the time. And every time that happens, it'll make a mistake. It'll put the wrong letter in some genes, and that's called a mutation. While I've been speaking to you, my body's done loads of mutations. It happens to us all. It's just part of being alive. And the body deals with it and deletes the ones that might cause problems, or the mutation doesn't matter. But what happens is a mutation occurs probably at random initially, and then it doesn't know it's mutated. So the two daughter cells have got the same mutation, and then the granddaughter cells have the same mutation, and so on, until you get this population of cells that are sort of growing by themselves. And then the body recognises it's got too many of those cells, as it would do normally, and sends a message back to say, slow down, we've got enough of you, switch it off. The problem is that this mutation is in the brake, if you like, that understands the message, so it can't switch it off, so it continues to accumulate. And so those cells accumulate until they potentially cause a problem. And that's what any tumour is. So a benign tumour, and I've got lots of benign tumours where it happens and for some reason doesn't continue growing. And then any tumour, lung cancer, breast cancer, anything like that, lymphoma, is different cell types that have done exactly the same thing. And so understanding why it's gone wrong is critical to be able to switch it back on. It's like, as I said, mending a car. If you don't know what's wrong with it, you can't fix it. And it's the same thing with leukemia or cancer in general. So CLL has one of the advantages, we can get lots of cells from patients and we can understand it in much more detail. So we're probably ahead of the curve in terms of the other tumours, because for one reason, because we can study it much more closely. So we have this excess growth of cells, and that's why we get swollen lymph glands, because the cells try and live in the right place. They try and live where they should live, which is lymph nodes, spleen, the bone marrow, the blood. So nowadays, this is different to a few years ago, 85% of patients are diagnosed from a routine blood test, inverted commas. So they go for a well-person check, they go for an operation, whatever test. I can tell you that we almost screened the population, and when I was at Wakefield, which has a population of about 500,000 for our area, we did 250,000 blood tests a year. So we're effectively screening the population, although some of them are done multiple times. And so 85% are stage A with just a high white cell count.
Sorry, Professor,
Yeah.
does that mean you don't need to remove the lymph node?
There are situations where we need to do lymph node biopsies, but if we have a high white cell count in the blood and we don't have one area of big nodes that we're worried about, then generally we can make the diagnosis from the blood test. But if you have some patients don't have white cells in the blood that we can see, and then we have to get a lymph node out because that's the only place we can see it. Or if there's one area that's big and the rest of it isn't, we want to make sure it's not changed, so we would do a biopsy then. So we don't often do lymph node biopsies. It actually hampers our research slightly, because if we knew what was in there, it would help us a bit. But it's obviously that's not a reason to do it. But some people do find aspirates of them. So we wouldn't routinely do a lymph node biopsy. Yeah. Okay. Any other questions about that? So in terms of the stage A patients, we now have indicators that tell us whether a patient is going to in the future need treatment or not. So about half of those 85% of patients who are presented incidentally will never need treatment. And we've got some tests that will predict for that. We can talk about it later on, but I won't go into the details. VH mutation testing is probably the best way. But no test will tell a patient they're definitely going to progress or they're definitely not going to progress. There's no test that will do that. Probably the best thing is time. So if you've had no change in your lymphocyte count over a year or two, then it's very unlikely it's going to cause a problem. Although, of course, that doesn't help the worry in the first few months of the diagnosis when you don't have that information. Although sometimes, actually, I often look back and find blood counts have been done in the past and the cells were there 5 years ago, and that helps. So if you can get old tests that then says, okay, it was there 5 years ago, it's a little bit higher now, we're not as worried about it than if someone's just had one test. And so that's stage A CLL, but then half of those patients and then the other 15% will present either with big lymph nodes or the bone marrow being involved. So that what happens, can I go back, Chris? Sorry, Jeff, on this? So these cells live in the bone marrow as well as in the lymph nodes. So if patients present with big nodes, we wouldn't necessarily treat someone with just, say, moderate-sized lymph nodes because they're not necessarily going to cause a problem. And some patients struggle with small nodes, other patients have very big nodes and don't have a problem. So that in itself would not make me want to treat a patient with CLL. If they were progressively getting bigger, that would be different. So first of all, so I don't worry about, patients worry about it, but I don't worry about a small lymph node appearing and disappearing. It really, if it continues to get bigger, it's a different issue. Or if they're causing symptoms, that's a different issue. But also, of course, these cells are also in the bone marrow, and they eventually, if they get too much, will push out the normal cells and lead to low, not neutrophils, hemoglobin and platelets, and that's another indication for treatment. So we're generally following 4 indications for treatment, really. Okay. Perfect. So does that explain the biology of the disease enough? So the other issue I should say, and some of you may have experienced this before as well, is this is an immune disease. This is a disease of the immune system. And the immune system has to do 2 really important things. One is fight infections and prevent us getting bad infections. Secondly, it has to recognise us and not attack us. And a lot of diseases are caused by our immune system attacking ourselves by mistake, autoimmune diseases. Not in CLL, I mean, this is just generally in medicine. So bowel diseases, arthritis, thyroid, this tissue has its own immune system attacking it. And the immune system is really good at killing things if it wants to. And that's why these autoimmune diseases can be very difficult. In CLL, sometimes the immune system decides it's going to attack usually our own red cells, our own platelets. And that's called an autoimmune ITP or hematocytemia. Yeah.
How is that different to CLL? Because we've been told that hemolysis is something that CLL patients can get. It's not actually driven by CLL. So what would the trigger be?
Sort of mainly right. So I'll go back to my no, not the British Hair and Nail Society. It must be, let's see where we are. Okay. Okay, so back to this. So what I said was that the immune system recognises things that shouldn't be there and kills them, but it also recognises things that should be there and doesn't attack them. And that's really complicated for a cell to do because it doesn't know when it sees something what's part of us and what's part of that shouldn't be there. And so what happens is we have, and some of you have heard of T cells and B cells. So there are 2 main types of lymphocytes. There's T cells and B cells. And CLL cells are always really B cells, which is usually only 1 in 10 of the cells. And so what happens in a normal situation is a B cell recognises an antigen, so a bug or a red cell, if it's autoimmune hemolysis, and then a T cell speaks to it. And the T cell says, that shouldn't be there, kill it. Or that should be there, don't kill it. And so there's a constant discussion between T cells and B cells and B cells and B cells as to what they should attack. So the way I describe what your father's had is that you've now got 1,000 times more lymphocytes or 10,000 times more lymphocytes than you should have perhaps. And it's a bit like being in a crowded pub that you've got less T cells around and you can't speak to them. And so these cells then confuse the whole issue. And then the immune system gets confused because it's got all this random discussion going on in the background. And then sometimes the T cells it'll lead an attack on the red cells or platelets. So you're right in that it's not the CLL cells that are attacking the red cells or the platelets in those hemolysis or ITP, but it's the effect of having those cells there that confuses the immune system that then attacks it. And so if we had somebody with that sort of presentation, where the problem was hemolysis or ITP for those is a low platelet count, we would initially, if they didn't need the CLL treating, treat the attack against the red cells. Only if we couldn't control it without too high dose of steroids or would we then treat the CLL. Because if we get rid of the CLL, it generally gets better as well. But the side effects certainly the older treatments for CLL were greater than treating the hemolysis. So we would usually treat the hemolysis first. If that was, and most patients would be actually okay. But then if we needed to, we would treat the CLL. So it's indirectly linked, not directly linked, I think is probably fair.
Can I just ask one more question? So with the B cells, that recognises that this is the foreign, did you say, then it's the T cells. So that triggers a message to the T cells to then kill it.
Yeah, well, I'll come back onto that a little bit because of the new treatments. But what happens is that I'll do it now actually because it's probably easier to explain it to you, and then I'm going to have to discuss this anyway. I can talk about chemotherapy later on if we want to, but I'm sure that's not high on people's priorities. So, how do we get rid of that? So, what we have to do is understand how a B cell works, how a B cell recognises the things it should attack, and then what changes. So, this is my normal B cell, okay? And that's what a normal B cell looks like. And its job is to make, one of its jobs, I'm simplifying it a little bit, is to make antibodies. And so what all the B cells do in the lymph nodes is they make one antibody. They only make one. So each B cell makes its own antibody. So there are thousands and thousands with different antibodies. And it puts its antibody on its surface. It sticks the one that normally it would secrete out on its surface. And so you have basically millions of lymphocytes with their own antibodies on their outside, and they're floating around the lymph nodes. And then when, say, a measles bug comes along, and they don't do anything, they're just waiting to see what happens. And when a measles bug comes along, here we are, another measles bug, that then links onto the antibody to the B cell that's specific for a measles virus, and that sets a chain of events that leads to the growth of the CLL cell. So it's only when it sees its antigen, or it's the bug, does that stimulate it to grow. Okay? So, and that can happen whether it's a measles bug or a red cell antigen, so it doesn't know whether it's us or a bug. So then the T cells come along, we'll do over here. T cells come along and they interact with the B cells, and they say, this is part of us, this isn't part of us. And then that's how they then stop they delete the ones that are self-attacking. So what's happening in a hemolysis is that you've also got normal B cells here. So these are not CLL. These are normal, aren't they? But if this was CLL, we've got normal ones, and they are waiting. And then if the T cells are all busy speaking to CLL cells, they're not speaking to the normal B cells, and then the normal B cells can go and do things they shouldn't be doing, and that's probably why they go wrong. I mean, that's sort of trying to simplify, but I think that probably is what really happens. So what we find is that the treatments that work to stop hemolysis are the ones that affect T cells, that we damp them down because they're now, and get them, because these are stimulated as well, and they start growing and doing random things, and then they start attacking things. So T cells are even more complicated than B cells. They have lots of other jobs that attack things and do all the other things. We're trying to understand that, but they're not directly linked to CLL. That helps, but that's the association, if you like. So this process, where a cell is recognizing an antigen and then grows, is what makes the cell grow from one cell to billions in a day or two. So that pathway, which is really, it's not simple, it's really complicated, is, there's lots of different strands to it, is what drives a cell to grow when it sees antigen and stops it growing when it doesn't see antigen. So what happens in a CLL cell? So now we have a CLL cell, okay, which tries to behave normally. And I'm actually going to go back. Let's try and go back. No, it's just not. And then I'm getting there. Okay, good. So if we go back to this, so this pathway of these genes are very well known now. We don't quite know how they work together and what proteins are on, but one of them, I'll just talk about one, it's called BTK, which is it's the name of a protein. It's a stepping stone, one of the first ones in this pathway. And we know it's important because the bubble babies inherit no BTK and they don't make any lymphocytes. So we know it's critical to making lymphocytes. And actually, that's important to remember. These stepping stones we understand, and there's other ones, PI3 kinase, etc., etc. So they're important in the B cells. So going back to CLL cells. Okay. So now this is a CLL cell, and it makes its own antibody. So it's behaving like a normal B cell. But what happens with a CLL cell is there's two things that can happen. One is, this is quite recent, its antibody links to itself and stimulates itself. So its own cell is stimulating itself and switches on the pathway. So without anything from outside, the cell is growing by itself and it's stimulating itself. And that, over time, it's not normally as fast as against a measles virus, but it slowly increases the speed of growth. And that leads to the slow accumulation of cells over time. And that's probably one of them, in almost, I think, every CLL patient, that is a patient with CLL, that is what drives the disease. So it's an abnormal sort of stimulation through its own antibody. There is some evidence as well that sometimes it's a self-antigen, like a muscle antigen that we've all got, that also drives it. So there's two possible explanations, but they're the two stories. But we know that this pathway is switched on, okay, in every patient with CLL. I want to come back to that in a minute, but the other side of the equation, which we talked about before, was that these cells grow too much, and that's why, but they also have to die, so they have to kill themselves when they don't need to be driven. And that's called, in medical jargon, we call that apoptosis. It's a Greek name, but it just means cell death. And that happens all the time. That's why we don't, to every tissue, we're regenerating it by reprocessing and recycling all the things. And apoptosis is a normal process. And we have some genes that are switched on to make a cell kill itself, and we have other genes that are switched on to stop a cell killing itself. It's a complicated system to stop cells dying when they shouldn't die, but make them die when they should, so that we don't get old early. Okay, so, and one of the molecules is a thing called BCL2. So BCL2 is a protein that's switched on in every CLL patient's leukemia. And that switch is normally, prevents apoptosis. So if you've got a lot of it, the cells can't kill themselves. And so you have a second hit, you've got this growing too much, and it can't kill itself, and that's the challenge. And so we end up, and I often now use this sort of seesaw that we have in any CLL patient with CLL. We have on one side proliferation, which is switched on, and that's the antibody-driven thing. It's not a good cross. And we have cell death or apoptosis, which is actually switched off because of the BCL2, and therefore we get an accumulation of the disease, and that's the basic problem. Understanding those two things is really important because it's led to the treatments that we now have, which are changing the disease, and we'll talk about that a little later on. And so, going back to I'm getting good at this now. Okay, I'm going to make a mess of it. Okay. Already done that, haven't I? Okay, so what we can do is if we have a molecule that blocks BTK, we'll stop that growth of cells. And so we now have a series of different medications that will do that. And if we have a molecule that would block that, we'll switch back on the cell death and encourage the cells to kill themselves. And so going back to our map, that's good. So what we have on this side is the one that's really leading the way, I think, is ibrutinib, which is a tablet or capsule of a small molecule that switches off BTK, switches off that growth through the pathway of the cell. And what it does actually, if you use it, it drives the cells from the lymph nodes and the marrow into the blood and stops them growing. So it doesn't kill them, it just starves them of attention, if you like. So they can't continue to grow. And it's undoubtedly had a major impact on our patients with CLL. There are other ones as well. Idelalisib is one, which is a slightly different target that has more side effects. So it's really, we're stopping to use it as much. When we first did the trials, they looked exactly the same, and we had lots of patients who were rescued by both of those drugs, actually. But ibrutinib's now really led the way, I think, it's fair to say. Although Idel is still a useful drug. And then we have other ones, they're licensed, they're approved, and we'll talk about that a little later on after lunch. And then we have other ones which have now got names, zanubrutinib and acalabrutinib, and so these are more specific inhibitors that might be better. So ibrutinib hits what we want, but a few other things, and that causes some side effects. And these next generation ones hit less things and hit what thing we want to do harder, and therefore are more possibly less side effects. Whether they're more effective is debatable, because ibrutinib is really effective if you can tolerate it, especially if you use it earlier on. But at any stage. So that's changed the disease. And then the other thing I mentioned about BCL2, because it's switched on in all patients and leads to the lack of cell death, as I described, was an obvious target. And we've been trying to target it for at least 2 decades since it was described, and no drug's been effective until we had this drug venetoclax. And that's been really impressive. In fact, one of its main problems is it's working too well, that it kills the cells. Whereas ibrutinib starves them, this one gets them to kill themselves. And if you give a big dose straight away, they all kill themselves on the same day. And that's difficult for the body to handle. So we have to do it slowly over time. That's called tumor lysis. But that has been a really impressive drug, I think, as well. And even in patients who have failed to respond or relapsed after the ibrutinib type drugs. So the thing that's really impressive about venetoclax is the fact that we get some patients, even with just, this is a tablet as well, a capsule, with once a day doses to where there's no detectable CLL. And that's, if we're going to move towards curing CLL, we have, and what I mean by cure is that we get people off treatment and it never comes back and they don't die of what we've done to them. And so that's, sort of important, really. And so if we're going to do that, we have to get patients to negative remissions, because if we have treatment and we stop it and there's disease that we can see, it will increase and then come back. So a prerequisite to get to a cure is to get rid of the disease in patients. And I mean, it doesn't mean that even if you're on ibrutinib and you've got disease that's there, we've got patients who are 5 or 6 years out and are fine. So you don't need to cure patients. I mean, you can control the disease like blood pressure is controlled, and that's fine, but we might want to do more than that. So for some patients, controlling the disease is more than enough, but as long as the side effects are tolerable. But in other patients, they want to go for cure. And I think it's a discussion that we have to think about as a team looking after the patient, and the patient is the important part of that team, really. What we're aiming for, what do we want to achieve, And in the long run, we'd like to cure everybody and not have to worry about it, and maybe we'll get there. But so we've got to get to negative remissions, and venetoclax does that in about 1 in 7 patients by itself who have failed other treatments. If we add it to other things, it increases the response rate. And if we use it earlier, it seems to increase the response rate. So that's very encouraging. So what I've tried to explain to you is that the understanding in the biology of the disease has led to really dramatic changes in the treatment of patients with CLL, and also gives us the possibility, because we have more than one type of drug and there are other ones being developed as well and other pathways which are important, we can start looking at combinations. And for the diseases like this that we cure, so Hodgkin's disease, childhood acute lymphoblastic leukemia, some AML patients, acute myeloid leukemia, there are diseases we cure some patients, it's usually with combinations. So one drug is not usually enough to cure a patient for most diseases because the disease thinks of a way around it. But if you can corner it with 2 or 3 drugs, then you've got a better chance of it not being able to escape the cell that's growing. So that's really where we are, I think, in terms of the current treatments.
Can I ask a question?
Of course.
Venetoclax, is that the generic name for Venclexta?
Yeah, no, I don't use brand names, but yes. Because that's a good Scrabble word, but I'm not sure it's a very good word to use in general English, is it? Okay, so that was what I was going to talk about, the treatment. I should say that before we go to questions, just about detectable disease. So because this is going to be is important for our trials going forward and for patients, we use a phrase called minimal residual disease, which so if you think about it. And I think I'm probably partly responsible for the thing. We should really have called it measurable residual disease, because that basically means how much we can measure. I can't spell measurable. Or MRD. So basically, when a patient has CLL and we can detect it, there are probably a million cells in that patient. And if we reduce it by 1 million times, there's still potentially 1 million cells left. If you think about it, we can only detect a certain level of disease. Our test can only what's in the sample and how good our test is. And so we can, with our current test, go down to 1 cell in 100,000 cells, which is pretty impressive actually. And we might go down to 1 in 1 million in some patients and with some tests, but we're never going to be able to measure the last cell in the patient because because we're not taking all the blood out and measuring all the cells. So we may not. It might be hiding somewhere, so we just can't measure every cell. So when we talk about MRD negativity, we're not talking about cure, we're talking about we can't find any disease. That could be the disease is here, just below the line, or it's gone. And we can't measure that. We can model it. And Walter Gregory is a prof of stats here and did a lot of work in our trials. We've been doing lots of work on how long should we treat someone when they go negative, for when they might then not have any disease. So we don't want to stop when they've gone to here, but you want to stop when they're down here. And so we've done lots of work on that. And our trials now, we'll talk about trials, are looking at if you go negative in 12 months, giving another 12 months of treatment, because then you should have gone down to where we think is potentially curative for the frontline patients. So MRD is sort of an important concept from going forward for CLL and other diseases. So I'm happy to take questions.
Thank you, Professor. My knowledge is very minimal, so if I use the wrong language, I'm sorry.
Yeah, well, you can call me Pete, it's fine.
I'm kidding. When I was diagnosed with CLL, I was told it was called chronic.
Yeah.
Because it's not curable. You would live with it
Yeah.
as long as you lived.
Yeah.
You're now talking about cure. Does
So-
that mean that it might not be called chronic any longer?
No, I'm sure we won't change the name. I mean, we'd have to change too many things to change the name. But I mean, basically, there's in hematology, because we have lots of different leukemias of different types, we tend to split them historically into chronic and acute. And what that means really is that in an acute leukemia, and they're the children you see on the wards, those sort of patients, there's a really rapidly growing leukemia cell that will double so quickly that it just overwhelms the patient within days or weeks and has no check, and you have to then treat it, and then the patient can go into remission. So that's acute, whereas chronic is more like I described, where it's a slow process, and that's all it really means. It doesn't have any reference to whether it's curable or not curable, but having said that, with chemotherapy, acute leukemia is curable in a proportion of patients depending on the type, because it's very effective at cells that are growing really quickly, but it very rarely cures a chronic leukemia patient by itself, because it's much more complicated in terms of, it's not just the rate of growth, it's the apoptosis. So chronic doesn't mean it will never be cured, but with chemotherapy, it's probably fair to say it's not curable. I think, and I always say this to patients, and I am an optimist, and I think recently we're probably justified being optimistic, but I think we will cure this disease. and because of the combinations that are coming along, for at least some of the frontline patients, because it's much easier for a variety of reasons to treat patients the first time round, because the second time round the leukemia's learnt, it's much stronger, it's been educated, not against the things we've used. So the benefit we're going to get in the trials has got to be in frontline. We have to move into frontline so we can cure it. We will make cures from people in second and third line, and we may control it. We're doing that now at the moment. So I don't think it means that people will die of CLL nowadays. I would hope we would control most patients anyway, if that answers your question. Yeah.
Can I just say, you talked about a paradigm shift.
Yeah.
Does that mean that chemo will be out?
Well, we'll talk about the trials, but we have to base it on evidence. And so what we have to accept, what we have to understand, I think, is that some chemotherapy, certainly for patients who can tolerate FCR, we are curing with FCR, so just to go back to your point, about 15% of patients. They may be the good risk patients, but from our studies, that's what it looks like, that we'll treat them and we won't have to treat them again. And so we can't just assume that because it's not chemotherapy, it's better than chemotherapy. And so it's really important that we do trials that prove we don't need to use chemotherapy, because it is an effective treatment for most patients, although it has side effects which most patients don't want to be exposed to. And so and we'll talk about it this afternoon, but it's really important, and one of the things we've done in the UK and we're doing more of is to get through the trial stage as quickly as possible, so we can then change the treatment for all the patients. So I believe for most patients in the future, we'll get to a point where we have better options than chemotherapy. We may already be there, but we have to prove it. We have to prove it because we need to know what we're doing, not just believe it, and because otherwise we will. I can give you lots of examples where people thought one treatment was better and it proved to be worse. So it's really important we don't throw the baby out with the bathwater, and we have to get the best treatment. So that may be that we've tried 2 or 3 non-chemotherapies to see which is the best. And then we need to get evidence that proves it, so that when we go to NICE and other places, they say, well, if you get something that really works so well, it will get funded. If you get something that maybe doesn't work so well, you don't have the evidence, then you run into problems. And some of you have been to NICE committees and seen that. So if you have really strong evidence, it's relatively easy to get funding. So yeah, but I believe that is the correct statement, paradigm shift. Do that. So first of all, I would say that we've got a lot of patients in trials and in my clinic in Leeds and clinics around the country who are on ibrutinib, and it's brilliant. I mean, in terms of, many patients don't have side effects, some do, but some patients have very minimal side effects, and it controls the disease very well. And when we look at it, there's very low levels of disease there. And in fact, in our trials, we're seeing it just slowly going down still, even at 3 years. So there's a continuing improvement over time. And if you look at certainly the earlier patients that were treated, frontline patients, most patients are still on treatment out of 6 years and plus. And so we have to have good evidence that what we're doing is going to be at least as good as ibrutinib alone in those sorts of patients. So we need to consider trials in that group of patients. Should we add venetoclax or obinutuzumab or one of the other therapies to ibrutinib? I think I wouldn't personally recommend it outside of a trial because there's no evidence for doing it yet. But I think that is where we'll end up going in the end. And if we find that we're curing people and they're off treatment for a decade, then I think that we'll come back to that question. But I really wouldn't do it at this point now. We are, just before we get to, we've got plenty of time, but we're looking at a trial which we talked about, and 1 or 2 were the consumer, as they're called, representatives were in the meetings, of taking patients who are on ibrutinib and having low levels of disease, and then randomizing those patients to continuing or to an intermittent treatment, so stopping, watching them, and then when the CLL is visible but not causing a problem, retreat again. Because that actually could be better than continuous therapy. And you might be off treatment for years before you need to be retreated. So that's the trial we're actually planning to do. We've got some funding issues and other issues we have to deal with. It won't start till next year at the earliest. But I think it's a very sensible trial we have to do. So that's awesome.
Yeah, you were talking earlier about the ibrutinib being more effective on frontline patients.
Yeah.
Are we likely to see then that the regime of watch and wait change significantly
Okay.
in the future?
So,
I've been on watch and wait
Yeah.
for 15 years. I'm getting really fed up with it.
so there's two questions there. Because as we get better treatment, well, first of all, the first line question. So any treatment we use in CLL is better in first line and second line, is better in second line and third line. Because if we give, say, chemotherapy to someone and the disease goes to undetectable levels, or we've killed, all but 1 in 10,000 cells, those 1 in 10,000 cells are stronger because they've seen chemotherapy and they've been resistant, and they then mutate themselves a bit more, and when they grow back, they don't respond to chemotherapy as well. And usually, as a thumb, sort of rule of thumb, if you get half the remission with the same treatment again each time. So that shows you that the disease becomes more resistant. But the evidence is also it becomes more resistant to other treatments because it's mutated itself more. And so frontline is where we're going to get the biggest impact of treatments. In terms of what watch and wait, or watch and worry, whatever you want to call it, I think there's two statements. First of all, if we have better treatments when people need treatment, say we really do get to a point where this is a disease we either control without any problem at all, or we get rid of and you're not on treatment for a decade, why would you treat the patients earlier when we're going to be treating people who never need treatment? You may as well wait until they need treatment, and then you've got effective therapy. And rather than, because as I said to you before, even our best tests will not predict the likelihood of a patient going on to treatment. And so if we treat watch and wait patients, we're going to treat patients that would never be troubled by CLL. And they're going to have potential side effects. And I would say, I don't know, obviously, I'm not going to talk about individual patients, but if someone's had the disease for 5 or 10 years and it's not increased hugely in that time, the vast likelihood is they're mutated and they're not going to need treatment again. So they'd be, with the greatest respect, you'd be the last patient I would want to treat in a watch and wait trial. Most likely because of the non-specific, the fact that the disease, it depends on the reason, I'll go back to step, it depends on the reason you came off the ibrutinib. So if you came off the ibrutinib for side effects, then you haven't got more resistant disease, and I would assume, although we don't have a lot of evidence, that they wouldn't impact on the venetoclax response because it's a different pathway. If you come off because the disease grows through ibrutinib, is resistant to ibrutinib, then that shows that particular patient's leukemia is got more mutations, more sort of ability to resist, if you like, and therefore you'll get a lower percentage response. It's about 3/4 of patients respond. In the former, where it's side effects, I think the next generation inhibitors will probably find a space because we don't want to throw away BTK inhibition, ibrutinib type treatments. And the next generation ones will probably not have the same side effects. From our experience, we've got a few patients that we switched over. Okay, so I think stem cell transplant is relevant for a small proportion of patients with CLL, and it's getting smaller as we get more effective therapies. So one of the ways that one has to manage CLL, and I said it's a patient with doctor thing, is to plan the treatment. So don't just think of what you're going to do next when you get to that point. You've got to sort of have a strategy. And at some point, transplant for some patients becomes a possibility. And I tend to talk to patients even though I think it may not be necessary later on. Our aim is to get rid of transplant and to not need it, but there's still some patients who need it. And then there's other things coming along like CAR T cells and other immune therapies that will possibly replace transplant. So at the moment, the transplant rate has gone right down in CLL because of these new drugs. I think it'll come back a bit, but hopefully not permanently. So.
Could I just ask about your opinion regarding viewing CLL as some form of inherited disease?
Okay.
I lost my father to CLL.
Yeah.
I got CLL.
Yeah.
We suspect that my father's mother had CLL.
Mm-hmm.
And
Yeah.
my daughter has got raised lymphocytes.
Yeah.
So it's all a bit of a worry.
Yeah, that's true. So we have, within CLL, 100 CLL patients, a small number will have a first-degree family member with CLL. So it's about 3% of patients will have a first-degree relative who's got CLL. And we have some families, as you describe, who have more than one family member. I've got one family with 4 siblings with CLL, so it happens. And we've done a lot of work. Danny Kotowski, who was chaired the group before I chaired the group 16 years ago, collected a large number of families with CLL together to look at them, to try and understand if it was inherited. And what we found, we did a lot of fancy genomic testing on the patients, is that the families probably inherit a risk. They don't inherit CLL, because first of all, the CLL cells are different amongst all the family members, the different types, etc. But they inherit a risk of developing CLL. And what we found was that, and the way to describe it is similar to other tumours, that one mutation in one gene is not enough to cause CLL. Because if that was the case, we'd all have it. So it has to be, it's like a stepping stones of a number of different mutations. I oversimplified it by putting one mutation. There's probably 6, 7 mutations. And the way I describe it in families is you probably inherited 2 mutations. So there's therefore an increased risk of the other 4 happening in any patient. So you inherit a risk of it. It doesn't mean that a patient, and in families, you can get some patients with really difficult to treat CLL, and other people who never have a problem with it. So it's not that it doesn't normally run with the same type of disease. So.
What is the likelihood of individual treatments for CLL tailored by genetic tests?
Yeah, I think that's a really good question, actually. And so we'll talk about the trials that we've got at the moment, which aren't currently using genetic tests to stratify patients, apart from 17p, which is one particular group of patients, which is about 10% of patients, in the first treatment. It goes higher later on. So we already use that to stratify patients away from chemotherapy. We may well use VH mutation, which is the other one we use to predict outcome, to stratify, but we need to look at the trials we're doing at the moment before we get there. The next generation of treatments are looking at, exactly as you said, genetic testing. So what we've been able to do, and this is going to be, well, the UK's, England really, but the UK generally is leading the world probably, is understanding the genome of CLL, so all the genes in which they're mutated. And it's really complicated because there are lots of different genes and lots in different patients, and they fit into different pathways. But we're doing it in the Genomics England project, and we have 500 plus patients that we've done sequencing from our trials, and we'll have that data this year. And that'll give us a real rich, detailed information about every patient in the trial. And then we'll be able to answer your question. So we now have drugs. We're just starting a trial in Leeds for a particular drug that targets 2 different switches, different mutations. So we will have drugs that do that. The question for frontline CLL is, do we need them? Because, will I bridge to venetoclax? How good will it be? Or with triple combinations? And then, I think there'll be some patients who will need more treatment, and they'll be probably genomically driven as notch 1. There's lots. I can list a number of things which are being trialled now, and we're trying to get those into the UK trial centres.
If we could just thank Peter for your time.